Now we're going to be testing for CN1, the olfactory nerve. What I'm going to do is I have the patient close his eyes, cover his right nose, and smell the scent inside of the bottle. Can you tell me what that is?
Some sort of mint.
Very good. He's going to switch to the other side. What is that?
Mint as well.
Okay, good. If he was not able to smell that the same on both sides, that'd be an anosmia, which is where patients experience like loss of smell and also experience loss of taste. That's olfactory nerve. The second exam that we'll be performing is the optic nerve exam. And we're testing the acuity using the Snellen chart. With the Snellen chart, you're looking for two numbers. Right here on the left side, you have 20 over 200. The 20 is the distance of how far away they are from the chart. The bottom number is testing how far the normal eye can see distance-wise. So we're gonna do that now. Anthony's gonna be about 20 feet from the chart. He's gonna cover one eye and read as low as he can.
P-H-U-N-T-D-Z.
Switch eyes for me, please.
P-H-U-N-T-D-Z.
So that was just above the bottom row. He is 20/20 vision. You can also use the Rosenbaum card to do this exam, but Snellen chart's probably better. Here we're still testing the optic nerve, doing the visual fields exam. So I'm gonna have Ant cover his right eye and focus on my nose. And I'm gonna see. Tell me when you can see my hand.
Yep.
Tell me if you lose vision of it.
Nope.
Good?
Yep.
Tell me when you can see my hand.
Yep.
And when you lose it.
Yep.
Good. Switching over to the left side, left eye again. Focusing on my nose. Tell me when you can see the hand.
Yep.
Tell me if you lose it.
Yep.
Tell me if you can see the hand.
Yep.
Tell me when you lose it.
There.
That's the visual fields exam. Now we're doing optic nerve, ocular fundi. I got the ophthalmoscope here, and I'm gonna be doing the optic disc exam. In the optic disc exam, I'm testing for the sharpness and clarity of the disc outline. Looks relatively good. And if I saw a blur in the disc outline, that would be an indication of papilledema caused by increased intracranial pressure. Now, I'll be looking at the retina for any lesions of the eye, and also looking at the arteries and veins for any abnormalities. Switching over to the left eye. Looks relatively good on both sides. Now we're doing CN2 and CN3 optic oculomotor nerve. So we're gonna do the light swing test where I'm testing for his pupil reaction. So patient here is gonna stare at a wall distant, pretty focused. And I'm gonna shine light in both eyes simultaneously to see the constrictions of the eyes. So here we go. With that, you're looking for a CN2 lesion, which is both eyes constrict with light simultaneously. On the normal side, neither constrict with light on the lesion side. Compared to CN3 lesion, only one eye constricts with the light stimulation on both sides. Lesion eye does not constrict at all, but Ant over here looks relatively healthy and good. Here, I'm performing ocular motor nerve. I'm going to have the light in front of Ant's eyes, moving it in and out, looking for the symmetricalness in both eyes with ptosis, pupil size, and spasm. Normal findings that you'll see as we test right now is that the eyes adduct and abduct symmetrically. If there was a lesion, you would see almost a slow in the abduction and adduction, or a failure in one eye. Now we're going to perform the accommodations test, where I'm looking at his right eye coming from behind, and I'm going to see how the distance change affects his eye. Same on the left. Looks good. Now I'm testing oculomotor, trochlea, and abducens nerve, performing the H and X test in space. So what I'm gonna have Ant do is stare at the finger. He's gonna just follow. That would be H. Here's X. Very good. And with that, we are testing the muscles and the nerves of the lateral rectus, superior oblique, and everything else. Here we're doing the trigeminal nerve. We're doing the sensory exam, light touch with a cotton ball. There's 3 divisions of the trigeminal nerve. We got V1, the ophthalmic, V2, maxillary, and V3, mandibular. So he's gonna tell me if he can feel it inside of each zone.
Yep. Yep. Yep.
And you're gonna compare that right and left side. Tell me if it feels the same.
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 Yep.
Very good. Still in the trigeminal nerve, I'm going to produce the motor exam, where I'm testing the masseurs and temporals. So I'm gonna have Ant close his eyes, and I am gonna have him act like he's chewing down, and I'm testing the muscles in his jaw, seeing for symmetry or any abnormalities. Feels relatively similar on both sides. It's very good. Sticking in the trigeminal, I'm going to perform the reflex exam. So I'm going to ask the patient to open their mouth and kind of relax their jaw. I'm going to put my finger right on towards the bottom of the chin, and I'm going to use the reflex hammer and hit 2 or 3 times, seeing if I can get any kind of reflex. Very good. Here I'm testing the patient's coronal reflex, where I'm testing the trigeminal for afferent and the facial for efferent. Take the cotton ball, kind of wipe it on the outer part of their eyes. They should blink. Very good. Now moving into facial nerves, I'm going to test the 4 different facial muscles through expression. So I'm going to have Ant try and crease up his forehead right now by lifting the eyebrows. Very good. I'm going to have him close his eyes really tight and fight the resistance of me trying to open them. Good. Then I'm going to have him smile really hard. Good. And then I'm going to ask him to put air into his cheeks and kind of puff them out. Good. With that, facial nerves supply taste anterior 2/3 of the tongue. Moving into the vestibular cochlear nerve, I'm going to perform the rubbing fingers test. So he's going to tell me when he can stop hearing. Now, I'm going to test the other side. Now, relatively same on both sides. Still in the vestibulocochlear nerve, we're going to perform the Weber's test where I have a 512 hertz tuning fork. I'm going to create sound and put it in the midpoint of his head, and he's going to tell me which ear he hears the sound better in. Here we go.
Hear it louder on my right side.
Okay. In normal Weber's tests, you'll hear no lateralization, but as you just saw, there's an abnormality in the right ear. So with that lateralization, we're going to do the Rhiannon's test on the right ear, performing pretty much the same exam for Rhiannon. I'm going to create sound, but put it up to that right ear specifically. And he's going to tell me when he can stop hearing it.
No.
Good. Going into the last vestibular cochlear nerve test, I'm going to do the tandem gait, where I'm going to have the patient walk heel to toe towards me with his eyes open. And he's going to do the same back, this time with the eyes closed. Very good. Here we're testing for resting nagmus, where I'm instructing the patient to stare straight at a wall, and I'm watching for the eyes to shake. Resting nagmus is an involuntary rhythmic movement of the eye that occurs in patients when staring ahead. Now I'm going to perform the head thrust exam impulse test, where I'm going to have the patient stare at the hammer, and I'm going to move their head side to side, and they're going to still try to focus on the hammer. Visual fixation is maintained during this exam, and loss of visual fixation can indicate a lesion or ipsilateral side rotation. So here it is, staring at the hammer. Right to the right, moving head to the left. Looks good. Going into the glossopharyngeal nerve, which provides taste to 1/3 of the posterior tongue. I'm going to perform the gag reflex test here on the patient. And the glossopharyngeal is afferent sensory portion, and the vagus is efferent, the motor portion. So what I'm going to do is have the patient open their mouth and stick their tongue out, and I would take a swab and try to produce a gag reflex. Now we're going to test vagus nerve, where I'm going to look at the patient swallowing and assess them through palpation, looking for any lesions. Lesion on one side while palpating would allow it to not elevate properly, causing ipsilateral deventation of the uvula. So I'm going to have Ant here chew, and both sides of the jaw and cheek should elevate relatively the same. Feels the same on both sides for him. Very good. Now testing the accessory nerve. I'm going to do motor function for SEM first. Close your eyes. Now the trapezium. Good. Moving into the hypoglossal nerve, I'm going to do the tongue protrusion test, where I'm going to shine a light where his tongue is out. And I'm looking for atrophy and fasciculation but looks relatively normal. Last part of the hypoglossal nerve is I'm going to have him use his tongue to push out cheek side by side, looking for any lesions or problems with muscle strength bilaterally. And I would state any weaknesses to be a conlateral lesion. Go ahead. Switch to the other side. Back one more time. And last time. Very good. Nothing wrong there.